So we're going to go through the slides, the slide deck that you need to provide to the eligibility comment for inclusion within the trial. Just before we go through the slides, I had a couple of comments before lunch about coronary artery disease, about the ability to treat the patient by PCI and then undergo surgery. You can do that. If you find a patient with a concomitant coronary disease and aortic stenosis, and you think that this could be a kind of half-breed patient, you can do the PCI, but you must not consent the patient at that time. You do the PCI, you wait 1 to 3 months according to the type of DES or BMS that you have implanted, and then you bring back the patient, you get the consent, and this becomes either a AVR or a TAVI patient. So you can do so. If you feel comfortable doing this, this is a possibility. Or, on the other hand, you can go for a concomitant procedure, PCI, TAVI, CABG, and AVR. Okay, so I also had a comment about in some centers, CT scan as acquisition is part of the standard practice, so it's not going to be an issue. In other countries, it's not standard of care, particularly for the surgical arm patients. So what you at that time for the screening, we don't need you to upload the full set of images for the patient, DICOM images. There is not yet a CT core lab. We have an echo core lab. And if you, normally you should get the echo per protocol, according to the protocol, once you have consented the patient. So if you can do so, it's preferred. If the patient is not consented, you cannot send any image to the clinical, to the steering committee. So you need to consent the patient first, and you need to get a proper CT scan before that. So you will get a dedicated email address. That email will gather and collect all the slides from the patients, from the potential candidates. It will be distributed to the steering committee members and the PIs, and then we will review the slides within 2 days and provide a feedback within 2 days. And at that time, you will know if the patient is eligible or not, and if you can proceed with the randomization. So it's a very simple way. You send the slides to that address, and if you have any kind of question, you have dedicated emails for that. So we're going to go faster. So this is the type of slides that will be required for the submission. So the first slide, you need to enter the matrix of the patient, the age, gender, to make sure that it's a female, because it sounds logic, but sometimes we can forget that this is a gender-based trial, and we can propose sometimes male. We have to make sure that there is that it's clearly a woman that has been submitted. So the patient needs to be symptomatic. Yeah. So the NYHA class, and then the matrix, just to be able to confirm that the aortic stenosis is severe and so on. So if you have any item that you want to include in that box, just about the past history of the patient, you have that field that you can fill in. Just to provide clinical information to the steering committee members. Then we move to the echo assessment. The echo window is 90 days, 3 months. So if you have a past echo that provides these very simple informations, you can use that. And then once the patient has been randomized before the procedure, you need to repeat the echo. You will need to repeat the echo according to the protocol. So just to make sure that we get the proper images. Ideally, the initial echo should be per protocol, but if you don't have it yet and you want to consent the patient and send it, you can do so, but you will need to repeat the echo according to the protocol before the procedure. So these are very simple metrics, the gradient, the area, the annular diameter that has been estimated by the subannular plane, the LVEF, the severity of AR, MR. Make sure that you are within the 90 days window for that echo. And if you are out of window, you need to anticipate the date to which the echo will be repeated. So just to keep in mind that we have to remain in that window. And for those low flow, low gradient AS or asymptomatic patients, we want to record the ejection fraction, the movement, the difference in the mean gradient, and the amount of the micrograms, the amount of the butamine that has been used for the patient. Also required, if you can insert loops of the jet velocity, it's preferred, but still frame is okay. And it's the same for the long axis image of the left ventricle and the aortic annulus or the aortic valve. You can do that. Loops are preferred, but still frames are also accepted.
So I got this right. If the echo was done within 90 days, it doesn't need to be repeated, only if it was without the 90 days.
It doesn't need to be repeated if it has been acquired according to the protocol. If it's not according to the protocol, you will need to repeat it anyway. So it means that if it's feasible in your institution, you could say, okay, every AS patient is going to be screened this way with these views and so on, just to match the protocol, but it's not mandatory. Okay, so just as we said this morning, it's up to you. It's your responsibility to make sure that the patient fulfills all the inclusion criteria and the exclusion criteria, because we are not going to review all the blood testings and so on. So if there is something that is questionable, you can put it within these boxes, and then the steering committee members and the PIs will determine if the patient is suitable or not. If you have any doubt, either you directly contact us or you put this in the slides and we will provide an answer. So the risk scores, this makes sense, and we're going to collect all 3 risk scores, even though we mainly use the Euroscore 2 and the STS score in contemporary practice. We also want to record the logistic Euroscore just to get a better understanding of the risk profile of the patients. So coronary evaluation, you can put still frames. If you have time to put loops, it's okay. But at least one significant picture of the right coronary artery and 2 from the left side with the LAD and the left circumflex. If there are stenosis, we want you to provide your estimation of the percentage of stenosis in this field and calculate the syntax score and make sure that the coronary angiogram is within 90 days. So it's a quite large window. If you have somebody that has been screened in another hospital, you can still provide the pictures from that coronary angiogram. But if it is out of window, you will need to repeat it.
Is it mandatory to do the cath, or because sometimes we only do the CT scan, so we always do the CT scan for all our type of patients, and then we decide if we do the angio, because sometimes we just can exclude coronary artery disease and we don't need that.
So I have to say that what is recommended is a coronary angiogram, but we need to. We have to be quite consistent, and maybe for these patients that are being included in the trial, we need a coronary angiogram, just to make sure that everybody is assessed the same way. But if you already have a clue of that, of the absence of coronary disease on the CT scan, maybe you can do a very quick, really fast quick shots on the coronary arteries, avoiding to put a too aggressive load, contrast load to the patient. But coronary angiogram is required. Okay, and then the syntax score. So for the CT analysis, it's the same. The window is doubled, so it's 180 days, 6 months. So you have 6 months. If the CT scan has been done in another hospital, you can use it. Ideally, what we recommend is to get a non-contrast CT and a CT with a contrast. Non-contrast to be able to measure the calcium score if needed. If it's not part of your routine practice and you have a low flow, low gradient patient, you don't know if the aortic stenosis is significant or not, a non-contrast CT is recommended. So for example, in our institution, it's systematic, non-contrast and contrast. So it's really about adapting the protocol that you use. It's not a big, shouldn't be a big deal. So we want to see the dimensions of the aortic annulus. If you have a steel frame with the metrics, the measurements of the annulus, with the perimeter, the area, everything, min and max, all the softwares provide that. Be sure that we can clearly identify all these metrics in that window. It's the same for the LVOT and the sinus of Valsalva. And then you report everything here, just to make sure that it correlates, and we are talking about the same patients. And there aren't any exclusion criteria concerning coronary height or dimensions of the sinus of Valsalva, but we want to make sure that the patient is not at extreme risk of coronary obstruction. So we ask you to integrate the dimensions of the sinus of Valsalva, the STJ, the coronary height both from the left and the right side, but also the amount of LVOT calcification. And so it should be, maybe if you have a extremely calcified LVOT, you should make sure that we see the outflow tract clearly to appreciate the amount of calcification in that window. And then the femoral axes, we only ask for a short axis of the minimal diameter of the common or the common femoral artery or the external iliac at the minimal point, just to make sure that this is a suitable transfemoral candidate. And then we ask you to report the minimal and the maximum diameter achieved both by the right and left common femoral arteries. And at last, a 3D rendering, a 3D reconstruction of the iliacs, the terminal abdominal aorta. If you have everything from the aortic arch and then the abdominal aorta in the iliacs, it's better. If you want to focus on the distal abdominal aorta and then the iliacs and the common femoral artery, it's also accepted. Better is to see the overall arch and everything, if you can do so. But focusing on the distal part is also fine. And then at last, we ask for your decision about the planned valve type, the size, S3 Ultra, the size, the access site, and when you plan the procedure, just to make sure that you remain within the window that should be around 28 days for your patient. So it's going to be, if you have an idea or already an idea about the surgery, you can put a word about the planned procedure there also. So that was all. So you see it's quite simple. It's not extremely demanding in terms of items to filling, but these are very specific items, just to make sure that this is a female, symptomatic, that fulfills the inclusion criteria with no exclusion criteria at all, and a suitable anatomy if the patient is randomized to a transfemoral procedure. So it may sound a lot of work at the start, but once you get used to that, it's very fast to achieve. Okay, do you have any comments, any question?
Oh, I just like to make a comment because at least in our center, we're not used to treating surgical candidates with TAVI. They go, as I said before, they go to surgeon. So that would be the point where we will get the patients from, I think, from surgical clinics. So they usually get the angiogram already done, echoes done, the carotids are done. The only thing that's missing really would be a CT. So at that point, the surgeon will have to, or someone identifies the patient as in a pre-screening process and says, look, this is a possible candidate, let's get a CT, and then we can screen and randomize the patient. Is that correct?
It's exactly the sequence that you will have to apply if the patient is from the surgical arm and CT is not routine, done in routine.
Okay, thank
you.
I
would do that. Identify the patient, potential candidate, and bring him back for a CT scan and then finalize the eligibility.